Good afternoon, everyone, and good afternoon, our viewers. I'm called Naisu Lovisa, a nurse working in Mulago Hospital, Accident and Emergency. I'm so delighted to have this opportunity to moderate in our today's session. That is the 30th session under Medical Emergency Service Department. The topic today is trauma principles. In the house, I'm so glad to have other presenters with me. Allow me, fellow presenters, to allow you introduce yourself. It is going to be a self-introduction. Just from my left, and we continue like that, please. For the interest of not mispronouncing your names, I love to see you introduce your own self. Thank you so much.
My name is Mary Ellen Lyon. I'm an emergency medicine physician working here with SEED and teaching at Makerere University Emergency Medicine residency for the MMed residents and working at Mulago with Sister Lovisa here.
Thank you so much. Next.
Thank you very much. I'm called Ronald Kiweewa. I'm a general and laparoscopic surgeon working with St. Francis Hospital in Nsambya. I have a background in trauma, so I have done ATLS and the ACLS severally. So I have a very special interest in the trauma and hope to pursue traumatology someday. So teaching in the postgraduate school in Mother Kevin Hospital and Nsambya Hospital and Islamic University in Uganda, particularly disciplines rotating around from. I'm glad to be here.
Welcome, Doctor, for that and those remarks that you have given us and good introduction. I think our viewers, you have heard that we have the experts within the house. And we believe and trust that the session is going to be lovely and enjoyable. Over to the next person for self-introduction.
Good afternoon, viewers. I'm glad to be here. My name is Brian. I'm an obstetrician by training. I just have a passion in emergency medical services, and I am very passionate about supporting that field to grow and spread across Uganda. So welcome to yet another session in service of that goal, and we thank our presenters today for the great work they're doing. We hope to have fruitful discussion.
Thank you so much for that wonderful and lovely introduction that you have given to our viewers. And I want to rest assured that our viewers in the presentation, we really have the experts who are going to take us through. Without wasting time, you are aware that we are here for strictly 2 hours. I want to extend my thanks also to our government of Uganda, and also to extend my thanks to our partner, that is CD Global, for giving us yet another opportunity to have our people within our country to benefit. We are one of the countries that has been faced with a lot of challenges of trauma cases, and yet we need to do a lot of teaching to our health personnel so that we can also join into this big struggle of preserving life for our own, that is our Ugandans. So thank you so much. Is there anything that you'd want to put across? No.
Not at
So,
all.
okay, thank you so much. Straight away, I would like to go to the second agenda on our program is our case presentation. And on that note, I want to go straight away to invite our presenter who is on the online. And this one is none other than our own Dr. Rebecca Nabaweera. Please, you are welcome. This is our doctor who works with the Bombo Military Hospital. Our viewers, please pay much attention and listen to this case presentation. It is from this case presentation that we are going to progress to see how best we should be able to handle our trauma patients in an advanced trauma life support principles. Pay much attention so that you can grasp as much as what you can in this session. Thank you so much. So straight away, I want to hear from our case presenter. I hope you are there. That is Rebecca Nabaweera. We invite you to give your presentation of the case. Thank you so much. Welcome.
Thank you. My name is Rebecca Nabaweera. I'm an intern doctor at General Military Hospital Bombo.
Yes.
I'm glad to be. Oh God. I'm glad to be the case presenter for today. Yeah, and we are going to start right away. Dear colleagues online, good afternoon. Thank you so much for being part of today's echo. Yes, so our case presentation, as we all know, today we are talking about ATLS, and ATLS in full is Advanced Trauma Life Support. And we know that ATLS has both the primary and the secondary survey. This is what we are going to be looking at today in form of a case. Yes, so our patient was SS by initials, a 27 years old male from Kawempe, and he was a motorcyclist. He presented to us with complaints of severe abdominal pain for 2 hours, and he was also bleeding from his left lower eyelid, still for a period of 2 hours.
Flexing.
The history of presenting complaints, as you've heard, he was 27 years old. He's a motorcyclist. His presenting complaint was bleeding from the left lower eyelid and severe left upper quadrant abdominal pain, following head-on collision with a speeding truck. On impact, he fell head first, face down, and he had no history of loss of consciousness, no convulsions, no headache, no vomiting, or he was not bleeding from the ears or the nose. Yes. On examination, now this is our primary survey. And we know that in the primary survey, we are identifying and managing the most immediate life-threatening pathologies under the ABCD umbrella. So the airway, okay, sorry, someone says my voice is low. I hope you're able to hear me. The airway was patent and there were no secretions from the mouth that would maybe give us some obstruction or something. The breathing, he had bilateral equal air entry with vesicular breath sounds. When we went to our C, which is the saturation, we had severe conjunctival and palmar pallor. The extremities were cold. He was tachycardic with a pulse rate of 128 beats per minute. His pulse was weak and ready, both the radial and the salis pedis pulses. And then his blood pressure was 87 out of 58, hypotensive already, and we had a capillary refill of 4 seconds. When we reached the point of disability, we tried to assess his GCS. He was fully conscious with a GCS of 15 out of 15, and his people were equal and reactive to light. Yeah, so from here, something small, maybe before we go to the next slide. From here, we are seeing that our main point of emphasis was in the circulatory system. That is where we had our challenges. But as we know, we are doing ATLS and we are managing the immediate life-threatening. We are identifying them. So we see that there is a problem with the circulatory system, but we are not yet sure where the secondary survey. But as we are doing that, after establishing that, we shall see how we handle it later. Yes.
I wanted to come there. I don't know whether those things are still.
Next slide, please. Okay, so for the part of secondary survey, we do this from head to toe. I still identifying what would be wrong with our patients. So the head and neck, we remember we had a bleeding laceration on the left lower eyelid, and we had multiple bruises on the head. Yes, his neck was soft and non-tender. When we came to the chest, he was not in respiratory distress. He had a respiratory rate of 14 cycles per minute, and his SpO2 was 96% on room air. The chest was symmetrically moving with respiration. It was non-tender on palpation with equal expansion, and it was resonant on percussion. With bilateral equal air entry, vesicular breath sounds as we have seen earlier, and then the heart sounds 1 and 2, no added sounds. When we reached the abdomen was mildly distended. We had a bruise on the left upper quadrant, and it was soft. And he had marked generalized tenderness with guarding. Yes. Okay. There is a missing slide here, talking about the pelvic regions and the lower limbs. With the pelvic regions, there were nothing really significant. We did a spring test and it was negative. We had no tenderness there. We had good bladder and bowel control. When it came to the lower limbs, we had no bruises, we had no lacerations, we had normal muscle power, normal tone, and normal muscle bulk there. So that was our secondary survey, head to toe. We made an impression of a 27 years old male with soft tissue injury and in hypovolemic shock. You are querying visceral organ injury secondary to blunt abdominal trauma. Because as we have seen from primary survey, the saturation was impaired. This is a patient who had hypotension, he was tachycardic, he was sweating, and at that time, we were already in hypovolemic shock, but we had not identified the bull in the house. And now, when we came to the secondary survey, that's when we realized that our patient had a problem with the GIT. And that's when we had the abdominal distension. We had a bruise in the left upper quadrant. Next slide, please. Yes, while we were doing our primary survey, as you know, trauma is a collective effort. It's not an issue that is supposed to be handled by a doctor alone. It's a multidisciplinary thing. As we were assessing, when we realized we had a need in our circulatory system, we had to insert 2 large bore cannulas, and then we had to start IV fluids straight away. But as we were doing that, we picked up a blood sample for grouping and cross-matching, and we cross-matched 2 units of blood. We gave this patient IV Ceftrax
Thank you so much, Dr. Rebecca. We seem to have lost you. However, I want to thank you so much for the effort that you have made to make up this presentation. I want to thank you for the commitment that you have showed.
Sister Lovisa. Oh my God. Yes. Are you able to hear me?
Yes, we are able to hear you, please. Go ahead.
Yes, sorry. I think I have a network problem. As we
Understandable, please. Go on. We can now hear you. Oh, we can't hear you again. You are lost? You are lost. We can't hear you. However, as we navigate through the internet, which I think is the possible cause that we have lost on you, I want to thank you so much for coming up with such a presentation. I think we've had, as other viewers who are online, you have heard how the presentation is. Maybe when she comes back, she will complete with the few slides that are remaining. But meanwhile, we are waiting to get her back online. We are
yes, I'm
sorry.
back.
Oh,
I'm
okay,
back.
please. Okay, please,
I'm
go
back.
on.
Sorry.
Yeah.
I don't know what's happening to my
Mm.
network. Well, our plan was to do eFirst. Thank God, by the time I came in, someone was already posing a question, what is eFirst? eFirst stands for Extended Focused Assessment with sonar for trauma. It's an imaging modality. We are using sonography, and we are just focusing on the areas that we may expect to have a collection of maybe blood or something, especially when we are expecting bleeding in blood trauma. So here we look at the hepatic fractures, the splenic fractures, the right and left paracolic gutters, the pouch of Douglas. When it is extended like this one that we are planning to do, we look at the pericardium and the pleura to see if we have any fluid collection in such areas. So that is eFirst. We would relate it to an abdominal ultrasound scan, but we use it mainly for trauma. And our plan was to prepare the patient for emergency X-lab and STS of the eyelid. Next slide, please. Yes. Still there is a missing slide because we wanted to know how, like, which decision. Yes, we have a patient. The patient has, when we are studying, we are told that in blunt abdominal trauma, the investigation of choice is a CT scan to see if there is any bleeding or visceral organ injury. Why didn't we wait to do that? We realized that this is a patient who was hemodynamically unstable. In blunt abdominal trauma, there is a way we categorize these patients if they are hemodynamically stable, normal, or unstable. Yes. So the ones who are hemodynamically normal, those ones we can wait. We can do all the investigations that we want to do until when we see that, okay, now this is what we have, maybe let's go for X-lab. But then the ones who are hemodynamically stable, we can do some investigations, yeah? But the ones that are hemodynamically unstable, we don't really go into much of finding. There is what we call trauma-laparotomy, whereby that is the only way we are going to see what is wrong with this patient. And it is a final step in the pathway to delineate intra-abdominal injury. Like the patient, you think the patient is bleeding, you don't know the cause of the bleeding, we do a trauma-laparotomy and we rule it out. So this is what we did for this patient. he was hemodynamically unstable. We couldn't wait for most of the investigations. So we prepared for an emergency X-lab straight away. Good news is the X-lab was done and it was successful. During our surgery, we found hemoperitoneum, like the whole peritoneal cavity was filled with blood. We had also that contents.
Excuse me,
Yes,
Dr. Rebecca.
Yes,
Excuse me.
sister.
Yes. Yes.
Yes,
Thank you so much. However, I was requesting that maybe we can handle the questions and other things later. That let's focus on the slides, the presentation. Then the rest of the things we are going to discuss them as they come along. Is that okay with you? Yes. Thank you so much.
It's okay. But there's some of the things were in the slides, but okay, it's fine. Well,
Yes.
the hemoperitoneum, we had a naval sprain. If you know the grading of splenic injury, this was grade 5. And we had a perforation on the left curvature, on the lesser curvature of the stomach, and the appendix was inflamed too. So the interventions that we did, we expelled 3 liters of blood mixed with food contents. Like, as I said, we had gut perforations, splenectomy was done, and the gastric perforation was repaired. Then we did the appendectomy and we had to close this abdomen because now we were giving definitive management in the shortest time possible. While the procedure was running, after achieving hemostasis, we transfused this patient with 360 ml of fat cells. Next slide. And
Dr. Rebecca, just a minute.
Yes.
There are some viewers who are saying that your voice is so low so you try to project your voice that every other person in the house can benefit, okay?
Okay.
Yes. Thank you.
Okay. So post-operatively, this patient was admitted to HDU, and they continued with HDU management there. Significantly, he got transfused with 2 units of fat cells while in HDU. He was given antibiotics, he was given analgesia, and he was given IV fluids also. After 48 hours of management in HDU, the patient was transferred back to ward. And on ward, he was there for 72 hours and with no complaints. Yeah, thank you for listening. That was our case.
Thank you so much, Dr. Rebecca, for that wonderful presentation. I thank you for participating in the house. Our dear viewers, you have heard the case presentation. Straight away, I want to welcome people from Gulu. Thank you so much for being with us. The team from Mulago, you are welcome. And so many others that I'm seeing here that I can't mention for the interest of time. Otherwise, we recognize you and we appreciate. And together we can for this cause of our challenge that we have in our country that has been actually about the 10 most challenge that we have in our country, that is trauma, that has caused a lot of mortality and morbidity within our country. So let's join up and fight this. I would like to invite our viewers, if they have any response or reaction or any question to the presentation. Although I saw the doctor trying to answer some questions straight away, but you can officially put up your hands and give us a question if you have any question to the presentation of the doctor. I thank you so much for logging in and listening to us and being together with us. Thank you so much. Meanwhile, we're also going to send a pre-test, and you can continue doing the pre-test as we watch for those who are asking us questions.
I'm seeing questions in the chat. Should we have them, ask them verbally or just respond to them as we see them? So I see a question in the chat regarding fluids. Is the question about Ringer's lactate versus normal saline? I'm going to guess there's been a good bit of research about that recently. Generally speaking, there has been a shift toward using lactated Ringers in place of normal saline, just because it's a bit more of a physiologic fluid, except in the case of head trauma. That sort of more osmotically active normal saline is still preferred in the case of head trauma. So when you're dealing with a trauma patient and there's uncertain as to the potential extent of head trauma, I think reaching for normal saline makes sense. Do you have any thoughts on that?
Yeah. So in trauma, because the biggest cause of shock in most trauma cases is hemorrhage, and there's hemorrhagic shock. In the recent ATLS, they're advising that if all situations were ideal, the most ideal fluid for resuscitation in trauma should be blood. But the situation is not that ideal all the time. So if you were to choose crystalloid and you had saline and the rest, and you had lactated Ringers, you would choose lactated Ringers. It offers the patient advantage. It has more electrolyte, and there are more benefits you can get from lactated Ringers than normal saline. So ideally, you would want to resuscitate a trauma patient with blood. You replace blood lost with blood, but it's not possible to have this all the time. So if you were to choose crystalloid, I would suggest you choose lactated Ringers.
Thank you so much.
And most often we will go ahead and hang some fluid while, even in the best of circumstances, it can take a bit longer to get the blood. So you might have some fluid hanging while you get your hands in the blood. But certainly that's a good phrase to remember. You replace blood with blood.
Thank you so much for those response. Anything that you want to add into that?
Yes, going through the presentation, if we do not have any reaction from the other viewers.
Yes, please.
I did hear a comment on the C-spine. I would love to know if the cervical spine was paid attention to by doc, and if it was cleared. And then just an emphasis, just for comment, thank you for doing the pelvic spring test. As a matter of emphasis, it's stated that it should not be done so many times, especially if you discover that the patient has an open book pelvis and pelvic fractures and visceral injury for the viscera associated with the pelvic fracture. If they are the cause of your shock, and you discover that the patient has a positive pelvic spring test or the pelvic is giving way to give you an open book, it's recommended that you don't do it more than once. You don't call all your colleagues to see this open book pelvis, because then the patient is going to bleed worse. The other comments I think will come as we comment along the primary and secondary survey. I didn't say log roll. Maybe we shall have a comment on that. I'll give a general flat comment on CT scan, the role of CT scan and trauma like this. In an emergency situation like they had, where they had very clear signs of hypovolemic shock and they had a focus in the abdomen, they went ahead to do a laparotomy and save the patient. You should not be seen to delay to wait for a CT scan to make diagnosis if you have such clear signs. There are sometimes we have subtle situations. You're not sure if a patient has grade 2 or grade 3 splenic injury. The BPs are stable. They're getting tachycardic after a few hours. The hematocrit is not doing well. And you have access to this CT scan. Then you can do the CT scan. The CT scan is good for making out solid organs, because you can have a chance to have 3-dimensional reconstruction by the radiologist of the solid organs, and you can see if there's a laceration. You can see how deep it has gone and make a judgment based on that. So CT scan should not delay your clinical judgment if you think you're in shock and you need to do a laparotomy. The other issue is with the appendicectomy. Well, it's possible to have bruising of bowel, bruising of guts with blunt abdominal trauma. And I don't know if we had bruising of bowel or we had clear signs of appendicitis that had an indication for appendectomy. It is always indicated that in emergency surgery, you do not do more than what you have gone to do. You repair the perforation, lavage the abdomen, and leave. Lavage should be thorough. All the recesses of the abdomen should be lavaged thoroughly. To leave a drain or not to leave a drain is a subject for debate, but it depends on how thorough you've been, and that decision is left for the people in surgery. And abdominal wall closure, I think the teaching is such that we close the rectus and we do not want to close skin because we are not sure we have completely, maybe it's not possible to completely decontaminate the abdomen in one laparotomy. So you would want that if there is any effluent that will escape, it will escape through the margins of the rectus. So many times we discourage closure of skin in such contaminated trauma laparotomies. Okay, the third last slide talks about damage control surgery and damage control definitive surgery. I think we shall discuss this a bit later. I'm taking up a lot of time.
Yes, Doctor, thank you so much for the comments. Yeah, just allow me to interject. I don't know, maybe, I don't know whether Doctor is still online, that is Rebecca. There are some questions that doctors posed before you, that the issue of the C-spine, I hope you took note of it. If you have any information for him, please. And then he has appreciated the rest of the information that you gave on the pelvic test. But he also wanted to know whether you did the log roll and also the role of the CT scan, which he has already clarified. So if you don't mind, maybe you can clarify before we can engage them on how did you go about with the C-spine?
Okay. Thank you so much for that. Yes, the issue of the cervical spine, I think it came up within it was assessed, but in the slide, it came up maybe the second survey where we see the leg was soft and it was not tender. Like there was nothing significant in cervical spine. And the dog roll, based on our findings, we didn't employ it. We didn't employ it. Yeah.
Okay, thank you so much for that additional information. And if there is no any other question or reaction from the participants or our viewers, we straight away want to go deeper into the case that has been presented to us. On that note, in the house, I said I have the experts. We want them to take us through about the primary survey in the ATLS in this particular scenario. And this is none other than Dr. Mary. You are welcome to take us through the primary survey.
Thank you. So I'm just going to talk a bit about the primary survey, which I think is the most immediate thing that you do in the with ATLS and the most important. And the whole, are we going to do the pre-test or should I be doing?
I think we can have the pre-test received later as we continue because time is not on our side.
All right. So the primary survey, it refers to the things we talk so much about even here in ECHO, which is the ABCDE, which is the airway, the breathing, the circulation, the disability, and the exposure, right? And so you just work yourself. You just work your way through the letters. And the point of the primary survey is to identify life-threatening problems with the patient and then to address them. And so the reason that we do go in this order is because you're looking for the thing that would kill your patient the fastest, right? So with airway, you're literally assessing the pipe that runs from the outside world down to the lungs. Is that pipe clear? If it's not, your patient is going to die very quickly. So one of the first things that I will do is just, sir, can you tell me your name? If the patient can tell you his name, then the pipe's clear, right? In fact, you get a lot of information if a patient can tell you their name. If they can tell you your name, the pipe is clear, the blood is circulating, the lungs are working well enough to get oxygen into the blood, and the blood is circulating enough to perfuse the brain, right? Because they're able to tell you their name. So a patient that can tell you their name has already done pretty well on A, B, and C. So in this case, sir, if they're not able to get, I'm going to look for secretions and listen. Am I hearing any fluid there in that pipe? If I don't, airway is clear. The next thing you want to do is look at the chest and listen to the chest. Now I want to know, are the lungs expanding? Is air coming in and out of those lungs? And is it doing it on both sides? So I'm going to listen on both sides for bilateral breath sounds, and at the same time, I'm looking for chest expansion. And then I'm going to feel for radial pulses. If I have radial pulses, fine. If I don't have radial, then I'll feel for a carotid, because you lose them in that, a carotid or a femoral, because you're going to lose them in that order, radial, femoral, carotid. So if I don't have a radial pulse, I'll feel for a femoral. If I don't have a femoral, I'll feel for a carotid and call that out, okay? Then for disability, what I want to know is, I'm gonna look quickly. This is just a really quick neuro exam. So I'm going to do a quick pupils. I want to know if they're equal, if they're round or misshapen, and if they're reacting to the light that I show. Oftentimes what we'll use is our phones. Almost everybody keeps a flashlight in their pocket in the form of their phone. So if you don't have something like this, you check that. Then for E, it's exposure. You get everything off of the patient, and you're just looking, is there anything else that you need to know? At the same time that you're completely undressing the patient, we need to be very careful with trauma patients not to let them get hypothermic. Even in this environment, it's very easy for people to lose too much of their body heat when they're completely exposed to the environment. The other thing that we're going to do is we're going to do the log roll, and so when that's done, if there is a cervical collar on here, we're going to keep the cervical spine straight. Can I just show you here? And one of the most important things, I see people all the time doing a log roll or holding the cervical spine, holding the head. But it's not that I need to hold the head, it's that I need to hold the head in relation to the rest of the body. Right? I need this alignment. I don't want the head here. I don't want it here. I want this like this. So what I'm going to do is put my hands under the shoulders and then lock in the head with my forearms, right? So that I'm like this, and I can turn the patient in one locked way like that, right? Because if I'm just holding the head, it's the neck is still able to move. And this is the exact motion I'm trying to stop. I don't want any of this motion. And I don't want any of this motion. So I'm going to grab the shoulders and use my forearms to lock in, and then I just move as a unit with the patient when we roll. That makes sense? Okay. So a couple more things just quickly about a primary survey. It's easy to forget that while I'm doing all this, critical nursing functions are happening, right? This primary survey assumes that while I'm doing all of this, someone is getting IV access. As soon as a trauma patient comes in, we need to get 2 large bore IV cannulas in. We need to get some oxygen on them through nasal cannula, if at all possible, right away. If we have a monitor to get them on, great. We need to be getting blood pressure. So if I'm working by myself, I'm going to have to do everything myself, and I'm going to work through these letters. But while I'm doing everything I just said, Anybody else in the room is getting some oxygen on that patient, getting some IV access, and getting a set of vital signs with like a blood pressure. So all of that can be happening while the primary survey is taking place, right? And for each of us who does the primary survey, you need to work out your way of doing it, and then you do it the same way every time, same words and everything. This is meant to be formulaic. You're not meant to be, thinking it through and what should I do next? It is not about that. This is about every trauma patient that comes in, you do it the same way every time. Every time. So I'm just going to go through it quickly and show you what it would look like if I don't have any extraordinary findings. I'm going to come up and go, sir, can you give me your name? Airways clear. Bilateral breath sounds. Radio pulses are present and equal. Pupils are equal, round, reactive to light. And then we would do the log roll and look at everything. Okay. And the last piece of the primary survey is that at any point when I'm doing the primary survey, if I find a pathological finding, if I find that there are secretions in the airway, I stop and fix it. The reason we go in this order every time is because there's no point in going on to breathing if there's no airway. If there's no airway, breathing doesn't matter, right? And circulation. It doesn't matter what function the lungs are in if air can't get there, and it doesn't matter if the blood is circulating if there's no oxygen in it, right? So we have to fix these in order. So if I come up here and there's secretions here, suction. If that does well enough, great. Maybe put an oral pharyngeal airway in and move on. If there's still a problem, then you're going to need to intubate to secure that airway before you move on. When I get to breathing, if I'm not seeing good chest expansion, if I'm only hearing breath sounds on one side, if the trachea is deviated, now I'm really worried. I'm worried about a tension pneumothorax, right? That I have to address before I move on, because if it is a tension pneumothorax, it's already affecting circulation, and the patient's going to arrest before I get to the rest of it, right? So fix the airway if you find something, fix the breathing if you find something wrong, and then with the circulation, when I get to circulation, am I still going, guys? Okay, when I get to circulation, one of the things I want to know when I get to breathing, if somebody's been doing vital signs for me, I want to know what's the oxygen saturation. When I get to circulation, what's the blood pressure? In this case, the patient was hypotense, right? A trauma patient who's hypotense is, that's from hemorrhagic shock until proven otherwise, right? So I've gotten through the thing, the immediate life threats, and then we're going to move straight into a secondary survey and hopefully an EFAST, because we're adding like extra exposure, that EFAST to try to identify where that hemorrhagic shock is. And I would already be calling a surgeon. Okay, I have a hypotense, I have a trauma patient with a low blood pressure. They're bleeding somewhere. And if I can't see it, I can't fix it, which means I need a surgeon. So as an emergency medicine doctor, I'm already getting somebody to call surgery because this patient's going to need an exploratory laparotomy. Okay, and I think we're going to move to the secondary survey now.
Fantastic. Thank you very much, Dr. John, for that.
Thank you so much, Dr. Mary. Allow me to address you as Dr. Mary, as I can't pronounce that other name.
That's all good.
Yes, thank you so much for this wonderful presentation and for the teaching that you have put forward. It has been colorful and wonderful. Me as a nurse here, I have some things that I've picked, maybe to represent the nurses out there, that the role of a nurse in airway. I marked that we have to ensure suction always and have to ensure the airway is the airways gadgets are available. Like you talked of the valve, the bag and mask, and your oxygen, and then I think the ports, I should check my ports if I'm in what? In an emergency room and I'm interfaced with such a scenario. I should have them all ready. And other things may be like the ETTs for management of airway, depending on how our patient will be. And also to be able to bring like OPAs, because those are all things that can help us into airway management. And maybe to my SACA, I should always check my SACA every morning to see that I have a functional suction machine.
Absolutely.
Because if we're going to handle airway, then we should have all these things near our crash cart and ready to manage the airway. That is something I'm taking as a take home, and of which I would think some of our nurses out there were also listening. What is the aspect of a nurse in this particular, what is the role of a nurse? I picked that and I've learned that.
Yeah.
And as you proceeded, I think I want to say that it has been so well articulative that people must have picked what you have said, though it has been very fast and quick, Yes, you have been a little speedy, but I believe they should have followed up as to how you have been assessing the patient. So this is very critical for my fellow nurses out there, that you must know how to manage circulation. She talked about the cannulas, the BOA cannulas, that it is the role of the nurse to prepare that. And the doctor in the beginning hinted about the quick investigation that we could do, like taking off blood samples and getting the HB and getting the grouping and cross-match, since somebody has got a trauma anytime, may warrant blood. And he emphasized that blood would be the first fluid that we should be thinking about. But looking at our environment and our scarcity of blood, that's why we chose Ringer's lactate. I think, Doctor, I learned that Ringer's lactate is more preferable to any other crystalloid fluids. And I'm also just echoing here to my fellow nurses that please, these are key things that we nurses who work in emergency unit must put at the back of our unit as a team to make sure we are able to to save the life of our patients. I'm sorry that I can't connect to some of my viewers for a small technical issue, but we'll receive their questions, and if they have any reaction to this examination that you have done.
Other questions at the end, surely.
Yeah, we will have them at the end of it, but I want them to keep these questions. Maybe they will have other areas. I've only also learned in the airway, but in the breathing, what should a nurse be preparing? When it comes to circulation, what should a nurse be ready with? And when it comes to those disabilities, as you said, the A, B, C, D, and then the E first, maybe Dr. Mary, the presenter of the case, tried to answer about the E first, but I'm sure there are many other people there. If you have anything that you want to add on as what does E first exactly mean? Even me, I would think it is a mere abdominal ultrasound scan and maybe the chest cavity. What does it look for? And what are these important things that one should look, that even me as a nurse, if they've done them on a side bed, that it can raise my concern to say I should look for a next person on team. Yes.
Yeah, the quick answer is the EFAST is just, an acronym for the ultrasound scan that we do on trauma patients specifically. And it's just, it's an ultrasound scan that just looks at, you're looking for any fluid in the abdomen, any fluid in the pelvis. You're looking for whether or not there's any fluid around the heart, and you're looking to make sure that both, you can tell by the ultrasound whether both lungs are moving and if there's any fluid in the lung cavity. So it's really basically just looking for any fluid in those areas. Is there fluid around the heart that I need to get rid of? Is there fluid in the lungs we need to drain? Is there fluid in the abdomen or pelvis that I need to be concerned about? And are the lungs expanding on both sides? That's the short answer. And the one thing I don't think I mentioned, it's most often nurses, is like a jaw thrust. If you're not getting good air movement through that airway, just putting your fingers underneath the jawbone here, right where see where it's sharp right there? Just put your fingers underneath the jaw and just lift straight up. It lifts the tongue off the back of the throat. And because sometimes when someone's lying there unconscious, the tongue blocks the airway. And just putting their jaw forward will clear the airway. And that's almost always a nurse will do that for us.
Thank you so much, Dr. Mary. I appreciate, and I've learned a lot, and I hope my friends outside there are also learning like me. And without wasting time, if there is no any other reaction to our presentation, straight away let's see what we do in the secondary survey of this particular scenario that we have.
So thank you very much. Before I rush into the secondary survey, allow me to make a comment on there's a preparatory phase that should exist in every trauma setting in the ER that we need to factor in before we receive the patient. And now that government and efforts are rolling out emergency medical services and we have ambulance services on board, it will be very crucial that if you're receiving a patient in the emergency room, there is an acronym that the American College of Surgeons Committee on Trauma has come up with that can quickly help you take a quick history from the EMS team, the EMTs who are delivering this patient to you. It is abbreviated as MIST, the MIST, where M stands for mechanism of injury, mechanism, and time. Okay, and time of injury, where I stands for the injuries identified or injuries suspected. Or suspected, where S stands for, forget what S stands for, but T stands for the treatment they've given so far. So there is this mist, mnemonic, that you can quickly ask for the EMT who has delivered the patient to tell you a few things about that patient so that you can factor them in your management as you proceed. Somebody is going to help me check out the list. So it will be important for you as the person managing in the emergency room to receive a little history from the EMTs and factor it in your management. It could quicken some of your management. Okay, somebody has found the S? Missed.
Signs, symptoms, significant history.
Yeah, signs, symptoms, and symptoms that the patient has. Okay, so when we move to the secondary survey, quickly, the secondary survey is a more thorough look, that's what I would call it, more or less, of the primary survey. So when Dr. Lyoti spells out the primary survey, she makes my work of explaining the secondary survey very easy. Of course, we shall assume that you already have your PPE ready. Okay, and after you have your PPE ready, what you're going to move forward with is to take an ample history, and after the ample history, you're going to do a head-to-toe analysis of your patient. It is not uncommon for people to do a secondary survey a day after the patient was admitted, especially if you had a very sick patient admitted in shock with obvious signs of abdominal visceral injury, and you have done the damage control apparatomy, taken them to ICU for stabilization, and they are stable. That's when sometimes you may find yourself having to do the secondary survey. So this ample history, it's important for you to take a very quick ample history, and ample stands for you take history regarding allergies, any allergies the patient may have. You take history regarding medications that the patient could be taking. You take history regarding the past medical history. Okay, are they hypertensive, are they diabetic? And sometimes pregnancy for ladies in childbearing age. You take history regarding the last meal or last menstrual period for ladies in childbearing age. The reason you want to know this is sometimes you're going to need these patients intubated very quickly with rapid sequence intubation, and you want to gauge and see, okay, the difficulty there in giving anesthesia. And then the instance for events leading to this situation. So you take a very quick ample history, and after taking the ample history, you run to a head-to-toe analysis of your patient. And this head-to-toe analysis, if I could just use this mannequin, is basically more or less a repeat of what we had in the primary survey. But this time round, more thorough, because it is at the secondary survey that you want to pick out all the missed injuries. It is not uncommon for patients to be discharged home with a simple pneumothorax. It is not uncommon for patients to be discharged home with a fracture of the fibula. Okay, you missed it, you did your laparotomy properly, you did a splenectomy, the patient spent 3 days on the ward and went home with a fracture of the fibula. So the secondary survey, in addition to catching anything else that you could have missed in the primary survey, is intended for you to find all those missed injuries that could have neglected as you are trying to do the life-saving maneuvers that Dr. Mary talked about. So it's a head-to-toe analysis of your patient, and you use all your clinical skills that you'll have in inspection, palpation, percussion, and auscultation. It is in the secondary survey that you'll pick a 1 centimeter laceration of the scalp. It is in the secondary survey that you'll pick subconjunctival hemorrhage on that side. It is in the secondary survey that you'll pick a 0.5 centimeter laceration on the tongue. It is going to be in the secondary survey that you will thoroughly pick rhinorrhea of CSF, okay, or leakage of blood from the auditory meatus. It is in the secondary survey that you should be able to pick emphysema of the neck, okay, emphysema of the anterior abdominal wall. So a thorough head-to-toe inspection of your patient basically describes your secondary survey, okay? You look for laceration of the head, you open the eyelids, you get your torch again, okay, and you retake pupillary dilatation or pupillary reaction, you look for subconjunctival hemorrhages, you look through the nostrils, look for any signs of hemorrhage, you open the mouth. It is in the secondary survey that you will find dislodged teeth. Okay, primary survey will not be commenting about dislodged teeth, broken teeth, laceration on the palate. Secondary survey, you have to be seen to talk about that. Okay, any other bruising in the face, discharge, rhinorrhea, or blood coming from the ears, the neck, any penetrating injuries, any obvious laceration, and then you come to the chest, you'll expose it again, and you inspect, palpate, percuss, and auscultate this chest. You'll move to the abdomen, you inspect, palpate, percuss, and auscultate the abdomen. If you did do the spring test for the pelvis in the primary survey, it's at this point that you look for pelvic stability as well, okay? And then you continue to the lower limbs, okay? You will palpate, looking for areas of tenderness, and you flex the joints, looking out for areas of tenderness, again, because you want to pick out any other missed injuries that this patient could have, both sides. And then you come back to the upper limbs, palpate again, and at that point you request the blood pressure to be taken in the secondary survey. You say, please come back, retake for me the blood pressure. I want to know what it is now. You will palpate again and flex the limbs because you want to find areas of tenderness that would raise suspicion for fractures. You'll do it on either side, and then you again instruct your team to perform log roll. And you're going to need about 3 people to do this. Somebody stabilizing the cervical spine for you, and 2 other individuals to hold there and there, and another individual, if this mannequin had limbs, to hold there and there, and then you roll the patient to one side. And then the fourth patient, or the fourth person, or the one doing the exam, will again check out the occipital area of the scalp, will palpate along the spine, all the way from up there, up to the sacrum, looking for areas of tenderness and trying to tease these out. It is at that point that you may look for and identify some other injuries in the back. Somebody may have penetrating injury in the back that you missed. may have an exit wound for, gunshot or something that you missed. It's at that point that you have to pick it out. And you also go scalpating on the posterior chest wall for these breath sounds and qualifying them, giving them quality. And it ends with a dictal rectal exam. You would love to end the log roll with a dictal rectal exam. Sometimes when you have pelvic trauma, you'll have a high riding prostate. There are some clues you'll get. You may have bleeding from the rectal mucosa. You may have, with the spinal injury, you may have deranged or lost anal tone. You must give a comment on some of these things towards the end of your secondary survey. So if you do a thorough secondary survey, by the time you end, you should be able to have suspected missed injuries and tease them out with appropriate investigations. Okay? I think at that point, it's important the patient then gets tubes as well, can get all the appropriate necessary tubes. They already had 2 large bore cannula. At that point, you'll decide, maybe we add a urethral catheter. Maybe we add an NG tube to decompress and lavage the, and all these other necessary tubes that you may deem necessary. Okay? And that basically, I don't know if there's some addition from Dr. Mary summarizes what you would want to do in a secondary survey.
No, I think one of the key points, though, for today's case, I think we would agree, is that with today's specific case, you would never reach the secondary survey, because in the primary survey, as soon as we got done, you would identify that this patient's blood pressure was low. Then the question becomes, once we've done the exposure, there's no obvious, source of bleeding. As he was just saying, it'd be part of the primary to press here on the hip bones, right, to see, because if there's a looseness there, then they could be an open book fracture, we call it, and then we can put a pelvic binder on. I think in a later echo session, we're going to deal with like some of the procedures that we're mentioning today, but we could then bind the pelvis to hold it together. And at that point, even if we didn't have an ultrasound, I would have, when we have that abdominal tenderness and a low blood pressure, I would, there's a presumed hemoperitoneum at that point, and he needs to go for an exploratory laparotomy. So the primary survey has told me this patient is too unstable to get a CAT scan or to hang out here while we do a secondary survey and, call a couple of consultants. This patient needs to go for emergency trauma. If that wasn't the case, if the vital signs were stable, then we would go straight into the secondary survey that you mentioned.
And probably that raises the issue with Dr. Rebecca and their findings, that this secondary survey probably should have come after the laparotomy.
Yeah.
Because after primary survey with an intervention, with resuscitation. And that resuscitation required us to do surgery, emergency surgery. So probably the thorough secondary survey should have come after the patient is stable following their emergency surgery.
And there is even, eventually, ultimately, what we call the tertiary exam, which is like the next day when, again, you go back over and make sure, because, as you say, they could have a broken wrist that you're not even going to notice the first day because they're so distracted by the pain of their open femur fracture that they don't even feel their wrist. Or, so there's like everything in medicine, you do it and then you redo it and you redo it. But I think the real focus of ATLS, the real power, life-saving power of ATLS is in that primary survey where you hear a wet airway, so you suction, or you're not hearing air passage, so you get that jaw up, where you have, unilateral breath sounds, so you put a chest tube in, where you have this open book fracture, so you put a pelvic binder, call a surgeon. It's, look for something, if you find it, fix it. Look for the next thing, if you find it, fix it. And when we got down to circulation, this patient has a low blood pressure, nothing obvious I can do. I'm just calling a surgeon and getting them out of the emergency department and into a surgeon's hands as soon as possible, because as ultimately proved to be the case, this patient was hemorrhaging internally.
Thank you so much, our experts in the house. Thank you, Dr. Kiweewa, for that teaching. I just also have a question, because I'm also in a session learning. Am I right to say that you can have a trauma patient and you do a primary survey and then you can do like a secondary survey a day or 2 days after? Is that possible?
Something like that. It's really possible because now we have to set our priorities for management of this patient right. We need to do the life-saving maneuvers first before we probably move into the other secondary things, just like it's called secondary. Sometimes you may discover that you need a whole 6 hours to have these life-saving maneuvers done. The patient comes to you, like they call it before, has a very terrible fracture of the pelvis. You have resuscitated and the patient is continuing to bleed. You will not leave that C until you have fixed the C. You look for an orthopedic surgeon, it's not available to do for your damage control, X-fix of the pelvis. You have put a pelvic binder, and even a pelvic binder is not helping much. So we have to go to theater, open the abdomen, and do pelvic peritoneal packing. Take the patient to ICU, they are stable, remove the pelvic peritoneal packs after 30 hours, and then the patient has stable BPs 48 hours later, this kind of thing. Then we can come back, whatever you choose to call it, secondary survey or tertiary survey. Now we can come back and look for fractures of the metatarsal and this kind of stuff. So it's important to pay attention to the life-saving maneuvers and to have our priorities there, okay? If a patient has a pneumothorax and you have established in your clinical exam that they have a pneumothorax, the most immediate intervention that has to come is a chest tube. That should be your priority, not completing a log roll and finishing, a secondary survey. The priorities, the level of arrangement of priorities should be such that you institute life-saving maneuvers for as long as it takes before you can come to the other things.
Thank you so much for that clarity. I think maybe the viewers also have their own questions and we'll see them at the end of the presentation. I thank you so much for that elaborate explanation about that. And maybe my other concern that I wanted to get some clarity was, for this particular presentation, we saw that they went ahead and did a laparotomy. And in the same way, other than the E-FAST, they didn't have any other investigations that they have done. Is there anything that you would want to comment about that? I don't know whether I got it right. But I saw in the
They got the CBC and the type and cross for the blood, right?
They did, I think, routine baseline labs when they took off the initial blood samples, which is appropriate, and quickly identified that what they needed to do for that patient was an emergency laparotomy. There are some other tests that the typical American College of Surgeons Committee on Trauma, ATLS, has talked about in investigating, for example, abdominal trauma, some of which I think are going to be phased out soon, like the diagnostic peritoneal lavage, the DPL. It's an invasive procedure. DPL, you may have to make a small incision around the umbilicus, introduce a trocar cannula, get some saline, pour it in the abdomen, shake the whole abdomen, then see what greets you, tend it to the lab for analysis. Because it's invasive, you could even perforate bowel. So I think in the 11th edition of the ATLS training manual, which we expect this year, DPL is going to be phased out. Because E-FAST is becoming more common. Some people have gadgets and they can now do E-FAST off their phones. So some of those things are being eliminated. So I think for our patient, whatever it is that we needed to do quickly, the team in the military hospital seems to have done so well, taken off baseline labs, and most importantly in their primary survey established that they had a deficiency in the C caused by blunt abdominal trauma, and they took care of it very quickly.
Thank you so much for that clarification. You've seen here some viewer asking us that can we have a clarification about fluid management once again?
Yes, I mean, in a trauma patient, the best and most important resuscitative fluid is always going to be blood. And because in this case, in a trauma patient with a low blood pressure, it is presumed to be hemorrhagic shock. And so you want to replace blood with blood. If you don't have blood, or if it's going to take you a few minutes to get blood, then hang whatever fluid you have. If you have a choice between lactated ringers and normal saline, I would say hang the lactated ringers. Yeah.
Maybe they need to know about the volumes. The volumes. Yes. I think right now we are moving to a situation where we want to do evidence-based resuscitation and infusion of fluids. So initially, Dr. Mary comments, I think we have a tendency to give a liter of crystalloid, and then we watch and see how the patient responds to this resuscitation. The reason we don't want to give huge volumes, and we shall see in other isolated injuries, if you have an isolated head injury, for example, isolated head trauma, and you're giving, and there's hemorrhage going on there, to give you a subdural or a subarachnoid or a dural hemorrhage, and you're giving too much fluid, what is going to happen is your cerebral perfusion pressure is going to increase, and then you're going to worsen the bleed. Or if you have a laceration on the spleen and a clot has been formed there, and you're giving too much fluid to raise the blood pressure, then you're going to dislodge the clot and worsen the bleeding. Or on another aspect, you could cause a dilution of coagulopathy. Coagulopathy is also a very serious situation in resuscitation in trauma. You could cause a dilution of coagulopathy and then send the patient to the grave quickly. So we want to carefully tailor our resuscitation and fluid infusion we want to tailor it and to have it respond to the vital signs that the patient will be giving us.
Yeah, and as he's saying, we have something called permissive hypotension, which means we're not, in a trauma patient, we're not trying to give them fluid to get them up to a normal blood pressure. You're only trying to give enough fluid to get that blood pressure sufficient to keep perfusing, right? The blood pressure needs to be high enough to be perfusing the heart and the brain. So, but you don't necessarily want to keep pouring fluid in of any kind, whether it's a crystalloid or blood, until they have a normal blood pressure. You're not looking for a specific number. You just need that blood pressure to be stabilized enough that you're getting sufficient perfusion, that you have the circulation that you need to keep the brain alive, to keep the heart going.
Thank you so much. Our experts in the house, I think the person who has asked that question, I'm seeing so many questions here and they are running so fast that some of them I can't capture them. I'm sorry for our dear viewers if I've not read your question. But there is another one here asking that do we give packed cell or we give whole blood? Still on the issue of fluids.
I think if you give whole blood, you'll be shooting two birds with one stone. You would replace volume significantly, and then the other components of blood, you would have a luxury of replacing them. However, depending on what your needs are, sometimes you may want to give past cells, or sometimes it's only packed cells available. But my thought would be that if you give whole blood, you'll be shooting, I think, two birds with one stone.
If you have whole blood, great. It's less commonly available, but if you have that, great. Don't, as is usually the case, you give what you have.
Thank you so much for that response. I hope our viewers, you have heard from our experts in the house. We have learned a lot, and I want to thank them once again for their knowledge that they have impacted to us. There is also a question that somebody posed, that when do we take off samples for lactate levels?
At the time that you're placing the IV access, you can draw off, your samples at the same time. There's no reason not to just draw labs when you place your IV access. I saw a question asking about GCS, which I'm sorry, I didn't mention the GCS, but that Glasgow coma scale is very important. It's part of if you haven't checked it ahead of time, it would be part of the disability, part of your neuro exam. And that's where you're getting a numerical representation of how awake the patient is. There's 6 points, 6 points for motor, 5 for verbal, 4 for eye opening, and it just gives you some idea of how awake the patient is. And if it's too depressed, there's sort of we used to use a benchmark of that the Glasgow Coma Scale was 8 or below, they needed to be intubated just because they're not awake enough to be swallowing their secretions when they needed to. There are exceptions of that. It's not a hard and fast rule, but certainly the GCS is an important part of the exam, and I'm sorry I didn't mention that before.
I think you did.
Oh, did I? Oh, hopefully I did. Hopefully I did. If I didn't, I'm sorry.
Yeah, of course, you can miss on something, but when it has been mentioned, thank you so much, Doctor. You captured that, and you much couldn't remember. I know we are managing our time well, but I was focusing on us looking at some of these questions because we are not so badly doing this on time management. So allow me pose these questions that our viewers have put forward us. Somebody, JK, is asking that what can you comment on anticonvulsants in head injury?
So we have a tendency of giving prophylaxis against convulsions for patients who we have identified have traumatic brain injury, because prognostically for their neural system, for their brain, it is important that they don't get convulsions. You don't want to see convulsions first and then give anticonvulsants, because every convulsive effect has a damaging effect on the brain. So in the trauma clerkship in the ER, if we establish that we have a patient who also has a traumatic brain injury, it has no harm to give prophylactic anticonvulsants. And routinely on their prescription, we have phenytoin there, we give them.
Thank you so much. Dr. Mary, anything that you
just,
want to
I think it's there's a lot of different practice around that. It's a good question. It's a good question. It's not an emergency medicine field. We don't tend to give prophylactic anticonvulsants, but I've noticed a lot of surgeons do. So I think that we don't have great research either way
around it.
Yeah.
Okay, thank you so much for that clarity. In the same line, I think you have already answered this viewer. She was also saying that do we give prophylactic anticonvulsants to all head injuries? I think Dr. Kiweewa has answered that, our dear viewer. Thank you so much for these questions. Another question, so that we can go through them so well. One is saying that at what stage is the CT scan necessary?
It depends on what we are investigating for. For the kind of patient that we had, just like you saw, the team, just by thoroughly doing their primary survey, were able to establish the needs of this patient and sort them without a CT scan. Not all centers have CT scans, yet we still have to have the capacity to make a diagnosis of, especially the emergency situations and procedures that need to be executed and have them executed. So, like I said, the CT scan, if you have a very stable patient, or a patient whose diagnosis is equivocal, you're not sure, and we have had them on the ward. It's 24 hours after they came in with trauma. The ultrasound scan told us there is some hemoperitoneum. The patient had a blood pressure of 100/60. Without resuscitation, it reduced to 90/50. Then we gave them crystalloid, and it came to 120/70. And since then, it has rotated, the systole has rotated between 120 and 110. The diastole has rotated between 60 and 55. But the patient continues to complain about abdominal pain. The hematocrit has increased. The heart rate is now 120. The initial scan told us a grade 2 splenic injury. This is a kind of patient that will need now a CT scan, because CT scan is very good, for example, in abdominal trauma, for solid organ injury mapping. They have a capacity to give you 3-dimensional reconstructed images of these solid organs. They can give you a 3D reconstructed image of the spleen, a 3D reconstructed image of the liver, a 3D reconstructed image of the pelvis, okay? And this gives you a clue that, to be frank, according to what I see in these images, when I see this laceration, and as far as it goes in the splenic hilum, I'm better off doing a splenectomy in this patient than waiting, okay? The patient is going to continue losing blood. For indications for neurotrauma, there are about 10 or 14. There are quite a number of indications for when you would need a CT scan in neurotrauma. I think it's more important in neurotrauma than anywhere else when you talk about isolated injuries of the body. But for abdominal injuries, that would be my submission, that absence of a CT scan should not delay your ability to institute for example, corrective intervention like surgery, especially if your exam has dictated so.
Thank you so much for that clarification, our viewers. You have heard from the experts. I'm not even one, but I'm also learning today. I'm so happy that I got a lot from our experts. Thank you so much for that clarification from Dr. Kiweewa. There are so many questions in here. We want to manage our time, and our viewers, in case your question is not answered now, I think we can, you will excuse us to have not read your question, and maybe if your question has not been answered, for the interest of time. Dr. Mary, maybe can you also put a voice on this question, that in head trauma with increased ICP, is there a guideline of monitor administration? Anything like a maximum dose of monitor? Some viewer is asking us that question. What do you have to?
You know, if you have increased intracranial pressure, or you have clinical signs of that, right? Maybe your patient is a bit obtunded and you've got one pupil is dilated and the other not, like unequal pupils. If you're concerned about increased intracranial pressure, then you can do some sort of osmotic therapy, either mannitol or hypertonic saline. Tend to prefer hypertonic saline, but if mannitol is what you have, then the usual dose would be about 1 gram per kilogram. So it depends on, if I have a 70 kilogram patient, I would give 70 grams of the mannitol. I would say the maximum dose you'd want to give at any time would be about 2 grams per kilogram, but the 1 gram should be sufficient. And then I saw something about, question about whether you can repeat it. You can repeat it like hours later, but with these with these kind of medical interventions or drug interventions for increased intracranial pressure, all you're really trying to do is buy time, right? You're just trying to get the pressure down a little bit long enough for the patient to get to the operating theater with a neurosurgeon. So there's not a definitive treatment. It's not something you can give the patient and then, you know, go get lunch and send the patient to the ward. If you're concerned about increased intracranial pressure, you need to be calling a neurosurgeon or arranging transport to someplace that has one. And if you want to sort of temporize in the meantime with a hypertonic or saline or mannitol, then that's certainly worth a try.
Okay, thank you so much for that clarification. Dr. Kiweewa, anything that you want to say about the maximum doses of mannitol and?
Well, I would just maybe just to give a comment that there is an increased preference nowadays for the hypertonic saline because of the advantage it confers to you over mannitol. And I don't know if we are soon going to see a replacement of mannitol management of increased intracranial pressure with hypertonic saline. It has quite a number of advantages physiologically. over Manitou.
Yeah, I still see mannitol more readily available in some places, but
Yeah.
certainly if you have the choice, definitely go with hypertonic saline.
Yeah.
Okay, thank you so much for those responses. I still have a number of questions here. Some viewer asked a question, though maybe I'll read it the way it is and we'll see if we can get meaning out of it. That how can you do, maybe you wanted to say what can you do when that patient respond and no pulses and there is X-ray, the result is bleeding inside on brain and abdominal. It is not very clear for me. I don't know if one can figure out what this person is.
So is it a trauma patient without a pulse?
I think he's talking about a patient. He's saying, how can you? I think he was like, what can you do when the patient unresponsive, maybe unresponsive, and no pulse? Okay, maybe you can ask it in a better way so that we can get your
You
question.
could ask it verbally, can they just
Or you can,
unmute and ask the
And then
question?
yes.
okay, meanwhile, I can be posing more questions as he is organizing himself. I don't know whether we still have him online or not. There is another question here that clarify more on patients with head injury. Suspecting epidural hematoma, do we need to give fluids like mannitol? This is a question from.
Do we need to give what?
Do we need to give mannitol? I can repeat. Clarify more on patients with head injury. Suspecting epidural hematoma, do you need to give fluids like mannitol? Meaning if somebody has an epidural hematoma, you have suspected it, do you need to go ahead and give fluids like mannitol, the drugs, let me say? He called it a fluid, but I think mannitol is
really
a
going to
drug.
need is a neurosurgical intervention. Again, if you have the feeling that that's going to be delayed in some way, you might be able to buy a little bit of time by using hypertonic saline or mannitol. But again, neither of those are treating the problem. They're just buying you a little bit of time. If you call a surgeon and they say, I'm on my way, and you want to, try to buy some time to use those.
Thank you so much, Dr. Mary, for that clarity. I think our viewers, you have heard from our experts in the house, and it has been very clear that none of them is a treatment for the problem, but the patient would need a surgical intervention in order to get better. So quickly, I will rush to another question, but what could be our target map for critically sick post-trauma patients? What could be our target map? I think the mean arterial pressure, because it is in capital here, for critically sick post-trauma patients.
Post-trauma?
Yes. He's talking about post-traumatic trauma patient.
In ICU now.
I'm trying to read exactly as the person has.
What is the target map?
What is the target map for the critically sick post-trauma patients?
Well, perhaps we could do like maybe in the emergency department and then
in the ICU or in the one thing I know, for example, for neurotrauma, you using that general mathematical equation that cerebral perfusion pressure is equal to mean arterial pressure minus the intracranial pressure. You would want to keep all the values of the stated pressures in specific ranges to make sure you are not. For example, there are disadvantages of having a very high map when you have a patient with an intracerebral bleed or any bleed. Okay? I will not want to mention values. I'm not very good with values. Maybe the intensivists are, but as a surgeon, I have at the back of my mind these general principles guiding me that you want the map to be just sufficient to maintain perfusion with whichever organ you want to keep perfusing. I will just give a general answer. I won't state specific values. Yeah. But if we had an intensivist here, I'm sure they'll be mentioning specific ranges. Yeah, I'm not.
Yeah, I mean, I think there's a lot of like caveats to that. Like I think we talked about earlier in the emergency department, in the immediate care, I think what we're worried about is perfusion. So you're checking clinically for as they did on the exam, whether or not the patient, appears to be perfusing well. Do they have cold, clammy extremities, or are they warm? Do they, if they're awake, then obviously their brain is being perfused. So you can sort of judge it clinically. In a general sense, you might think about a map of, I don't know, I hate to throw a number out there, but you could think of a map of like 60,
some range.
Is likely to keep the perfusion going, but I would avoid, where you can, I would avoid shooting for a number and really in favor of repeated physical exams to get the sense of how your patient is doing.
Oh, thank you so much, Tim.
I did see a question about tranexamic acid, which I think is an important one, particularly perhaps in pre-hospital. I don't know if that's becoming at all common, but certainly TXA or tranexamic acid, it's, a lot of these questions are sort of outside the strict ATLS beater, but certainly, we're increasingly seeing use of tranexamic acid in traumatic injuries. It has to be done within the first 3 hours, I think it is.
For TXA, I think there was a multi-center study some years back that established that it has a role in trauma, significantly in traumatic brain injury and other trauma orthopedics. They're using it. They give a gram in the immediate post-traumatic period. For example, if you have a good EMS system, your paramedics responding to a trauma patient many times ideally should be seen at the scene. Administer at least a gram of TXA, and then the other gram to be given, I think, over the next 8 hours. Okay, it has seen to save quite a number of patients. For those with neurotrauma who had initially small, insignificant, surgically insignificant bleeds, were admitted in the hospital, discharged after 24 to 48 hours, and then they returned to you a week later with a significant collection because they kept bleeding out like that. So it really has a role based on evidence for use in the immediate post-traumatic period. For neurotrauma, significantly, I would say that they have relegated TXA to mild and moderate traumatic brain injury, because the thought process is such that if somebody had a severe traumatic brain injury and they have a GCS of 8 or less, many times they are going to need a neurosurgical intervention, or they may need ICU to correct that. Your TXA will not be significant in correcting whatever pathology that will ensue. So there's a role for tranexamic acid in trauma. Very good question.
Thank you so much for that explanation and clarity about tranexamic acid in the head injury. In the interest of time, our viewers, I would request that you put up your hand and pose your question. But meanwhile, let's hand a second session that we have in the house. Then later we'll bring the experts on board to answer a number of questions. We have some questions that we are taking on. We'll give them to you with time, but let's have ourselves this time to respond to post-resuscitation care. This goes to our experts in the house, that is Dr. Mary or Dr. Ronald. You can give us your view about the post-resuscitation care. Yes,
I think in that sense, I think the most important thing about a patient is to keep an eye on them. Trauma patients can decompensate, and even a patient who got through the primary survey, the secondary survey, that doesn't mean that there aren't any injuries. It doesn't mean it's not a patient that you need to keep an eye on. So constantly re-examining the patients, very regularly checking the vital signs, keeping an eye on that blood pressure, that sort of thing, is really critical throughout the patient's stay, whether it's the emergency department or later up in the ward. The other thing, I think it's very easy to forget when you're the doctor or the nurse, but you would never forget if it was your own family member, for instance, is the patient experience, is pain control. I think we could be doing a much better job of addressing the pain control for our patients. Even in a hypotense patient, fentanyl is very hemodynamically stable. And I've seen a good bit of resistance, people not wanting to give pain control, thinking I'm not sure always. I mean, morphine can sometimes lower blood pressure, but not, most of the time you're still safe, giving it in most situations. And fentanyl is, as I say, hemodynamically stable. So let's keep an eye on the pain control and the patient experience in general. We take everything off of these patients. Let's keep them covered both for their own privacy as well as, keeping them from becoming hypothermic at all. Yeah, I think the most important part is just to continue to keep an eye on them.
Yeah.
Thank you so much for that post-resuscitation care info. I think our viewers, you have heard from our expert, and they were just Asia things, though they are always easily forgotten, as she has said. So let's keep a close eye to our patients, post-resuscitation, as she has said, taking care of a patient post-trauma calls for your observation. And I think this is one cardinal aspect of nurses. They always tell us that we must be observant. Using our own eyes, using our own hands, using our equipments that we have, but we should be very observant, that from a distance you are able to tell that maybe something wrong is going with the patient, even when you have not taken the actual measurement of the patient.
Exactly, and that's good enough. I mean, if somebody grabs me and says there's something wrong, I don't need to know, you don't need to be able to tell me what's wrong. If you just have a bad feeling, grab me. We can go to the patient together and figure out what's going on. Because sometimes it is almost just a sixth sense.
Yeah.
There's a change, maybe you don't know what the change is even, but there's something is different. In a trauma patient, move quickly.
Yeah.
Thank you so much. Dr. Kiweewa.
I think my comment on post-resuscitation care does not differ much from what Mary has said,
yes.
But it is basically answered by that tertiary survey sort of thing that we've been talking about. Keep reassessing your patients and looking out for those subtle areas which could be indicators for deterioration, because it's not uncommon for them to deteriorate later, or maybe you missed something and now it's manifesting. And we need to pay attention now to all the other components that contribute to the lethal triad of deaths in trauma. The acidosis, I think increasingly we are having people being able to do ABGs. Routinely in some trauma centers, they do ABGs for all these trauma patients. You want to make sure that you identify and very quickly deal with metabolic acidosis. You identify, prevent, and when you identify, you very quickly deal with hypothermia and coagulopathies. You prevent coagulopathy, or you factor it in your resuscitations. Sometimes we have a tendency to give massive transfusions. You're giving more than 4 units of blood in an hour. You're giving more than 10 units of blood in 24 hours, or a whole patient's blood volume in 24 hours. This is a massive transfusion. Now, what they call massive transfusion protocols, but it should always be at the back of the mind that when you begin resuscitating patients with these big volumes of blood, then you're going to need other things like fresh frozen plasma and this kind of stuff to avoid coagulopathy. So look out for massive transfusion and the effects So they could end up with hyperkalemias and so take care of massive transfusion and prevent the lethal triad and keep resuscitating, keep reassessing your patients.
Thank you so much for that additional information, which is very important and vital for us and our viewers and for our own country. I think me as a moderator, I don't have a voice, but I just want to say this, that on that note, I think we really need equipments to be able to maintain the patient's life and sustain. From what I've heard here, I think patient monitor machines should be readily available to those trauma centers. So it is an appeal to our people in the planning unit, especially in our health sector, in the budget, that when we are to improve on the health of our people in our country, or to reduce on mortalities, and especially mortalities, we need monitoring gadgets available in these trauma centers. And I have also noted that MBG machines, they are quite rare. I would say, but I don't know how expensive they are, but we are seeing that they are very important.
The government facilities, they're exceedingly rare.
Even when they are present, the cassettes are missing, you know. But as a general comment, to practice very good emergency medicine, it goes without saying that if possible, you would need these gadgets. You want to monitor your patient, you want the APG, you want all these scans available if you're to save this patient quickly. Unfortunately, the gadgets, help a lot, and probably we need them. So the people in the planning should begin factoring in. They are to reduce mortality and morbidity from this trauma. Then the gadgets go hand in hand with it. You need them.
Thank you so much for that submission. I hope our viewers and our planners have heard us, because this is on air.
Yeah,
and we will continue.
One other thing to state, maybe the question of the individual remains unanswered, that there is no pulse and there is, the teaching does not change. You have a patient without a pulse, without respiratory effort, you're going to initiate CPR. You're going to do CPR as you identify the reversible cause and try to deal with it. Yeah, it doesn't change much. You will have to start CPR, find the reversible cause. If it was hypotension, deal with it. If it is a pneumothorax, obstructive, something, deal with it. You must initiate CPR and identify the reversible causes, and you deal with them.
Thank you so much.
I would say, as far as that goes, that the percentage of successful resuscitations in trauma patients is quite low, because there's most often it's not something. Often it's something that you can't reverse immediately. But at times, there might be. That's why we're looking with the ultrasound probe for the fluid around the heart, because if that's what's happened, if we can get a needle in there and drain that, then we can get the patient back. So there's, anytime you don't have a pulse, begin CPR and then start looking for any possible reversible cause, right? If it's a tension pneumothorax, have somebody address that while the resuscitation is ongoing. I think the question probably comes from someone who's seen a lot of traumatic resuscitations, and we most often are not able to resuscitate because perhaps we don't have the blood. Often a traumatic arrest is from hypovolemic shock, and if we're not able to get fluids, to get blood to the bedside, we're not likely to be able to turn that around. But start it and look for anything reversible you can think of. I've been surprised before. Yeah, as well.
Thank you so much for that contribution. Within the house, we have received a new member. You realize. Allow me to take this opportunity. While we were not here, Rick, we had a self-introduction, and for that matter, I want to request to request him to introduce himself. That is introduction of the reactive concept. That is from Mr. Alani Nsubuga, please.
Yes, thank you so much, sister, and thank you so much, colleagues, our dear experts, as well as all our participants out there. My name is Alan Nsubuga. I serve at SEED Global Health as a senior program and M&E manager. I just want to take this opportunity on behalf of the SEED team and the Ministry of Health, as well as our country director, Irene Haire, to thank you so much for always taking time to participate in these wonderful presentations and exercises. So my role today is simple, to talk about the REACT teams. We've been talking about this concept for some time now. And just to refresh our minds, REACT simply stands for Resuscitation Action Teams. This is a concept that we, with guidance from the Ministry of Health, we are adopting as the project level team to ensure that we harness what we have accomplished so far, the knowledge sharing, as well as everything that we've been hearing from our experts. So what is REACT about? What is the intention of these REACT teams or the REACT concept? The primary outcome for this concept is basically to contribute further to the reduction in mortality and morbidity from emergency conditions within our health facilities. We also want to establish these functional teams in across all health facilities in the country, as stipulated in the Emergency Medical Services Policy, which was recently launched. We also want to use this REACT concept to functionalize the emergency departments or units at the various health units or facilities in the country. We believe that if it works out well, it will be a contributing factor to our emergency care units or departments. Again, the other intention for this REACT concept is to reduce in the facility response time for major incidents and other emergencies within the health facilities. So how will this work? REACT is a concept that revolves around formation of a team in each of our health units that constitutes between 5 to 10 members. These teams will be multidisciplinary, and they will include the different cadres that are available to support. So ideally, these teams will work as a team to prioritize emergencies. They will also attend to and support in stabilizing unstable critical patients in all departments. We hope that they will contribute to responding to emergencies within and outside the hospitals needed. We also believe that these REACT teams will contribute to documenting all patient cases that are received and handled by them. And lastly, we hope that these REACT teams will be instrumental in disseminating knowledge and skills to the other members who possibly are not privileged to be part of this. So what is our status to date regarding the REACT concept? The first phase is targeting 25 health facilities, that is national and regional referral hospitals. From this phase, it will be cascaded to the other health units, that's the general hospitals, health center 4s, and if possible, health center 3s. So the progress to date, REACT teams have been formed in 19 national and regional referral hospitals. And these teams, like I mentioned earlier, constitute of members between 5 to 10 in number. And what is currently being done, or what we hope to do, is to use a mixed approach to continue building capacity of these teams. By mixed approach, I mean there will be sessions, virtual learning sessions, riding on these echo sessions, but this will be accompanied by physical mentorships in addition to monitoring and evaluation. So mentors will come from the regions where these health facilities are located, and they will be supplemented or complemented by national mentors. So the new concept, this REACT concept, has been designed in such a way that in addition to the online sessions that we are receiving, such as this, they will be accompanied by physical visits routinely. And the plan is underway, and very soon the first set of physical visits will be rolled out. So we believe that these regular physical visits as a complementing factor of these online sessions will give an opportunity to the trainees to ask what possibly they could have missed out. There is also a possibility that yes, you learned about a certain case, but you received a similar but a little bit different. So the physical touch to this entire concept is what we believe will cause a difference. And lastly, one of the things we are really looking out for, we hope to ride on this concept to assess the impact of these interventions. And as we are assessing the impact, we'll be able to also recognize the gaps that still exist, which will foster the team, the planning team, that is the Ministry of Health, together with all other implementing partners, Emergency Care Society of Uganda, and SID Global Health, plus all the experts to support in closing these gaps. So colleagues will request you to embrace this approach. It is just coming to, as a result of the demand from the Ministry of Health, having recognized and heard the cry out there. And just like Sister mentioned, this will be complemented by some few items that will facilitate doing the work as and when it is needed. By items, I mean the materials that we need to do our work while serving the population. So I thank you so much once again. And to our participants online, we really are grateful. We do treasure the time you set aside to share your knowledge and also to learn from the experts that are here. Thank you so much.
Thank you so much, Mr. Alan, for that remark. For the interest of time, I just want to thank you for hosting us, giving us this forum, and for the efforts that you have put forward to make sure that we improve the health and the quality of life for our relatives, our population, and increasing on our economy at large. Because when we have a big population which is health, makes more economy, our economy grow. And when we have so many people who are disabled, people who can't add to anything, people who have poor quality of life after getting this trauma, from these learnings of today, I can see that with quick and access to this health care, we can do much and reduce on the morbidity, if possible, and also decrease our mortality due to our trauma patients. I want to thank everyone here who has participated. You have heard, he has quite good roadmap to the plans that whatever we are putting here, it is already in the pipeline within our government. We want to thank you so much for that initiative and for the way you are handling this. And we pray that everything come to the positive way as we are trying to anticipate that. We've been discussing so many questions, and actually added our viewers to send in their questions. But we are running short of time, that if we have not answered your question, we are sorry, but we are going to do all our efforts to see that we answer as much as possible. So at this time, allow me call upon, on our program, we have a post-test and screenshot that is being taken on by none other than our own, Dr. Thomas and Dr. Ibrahim. Please, over to you.
Thank you
Thank you everyone for joining in today.
The post-test was already projected. I hope everyone was able to attempt it. Right now we have the session assessment projected. This helps give us feedback about how the session went and how best we can improve these sessions. So I would like us all to turn on our videos so we can take screenshots. Turn on our videos. As we turn on our videos, we're going to get feedback about our post-test, how it went.
I think too, I saw if anybody has any additional questions, there's a link to a WhatsApp group for follow-up questions. And we'll do what we can to answer questions. There's no way to cover everything in one session, and I think everyone at this table is passionate about trauma care, so please feel free to post any questions we haven't been able to get to, and we will do everything we can to get to those.
So the answers to the post-test are currently projected. So I hope everyone is able to see them. Is everyone able to see the answers? So for question number 1, we got for the people divided in between the last 3 options. Question went: a 39-year-old man is admitted into the emergency department after an automobile collision. He is cyanotic, has insufficient respiratory effort, and has a DCS score of 6. His phobia makes it difficult to fit the oxygen mask on his face. The most appropriate next step is to, the correct answer was meant to be attempt orotracheal intubation using 2 people and inline stabilization of the cervical spine. I invite Kiweewa to comment about the question.
I think this question, we are having a patient who has who's going to pose a challenge to the rotate bag valve and mask patient. So you would want to establish a definitive airway as quickly as possible because the GCS is low and that patient has no control over their airway. So will you be able to perform a surgical cricothyroidotomy? I don't know how many people have seen the ease with which this is done in the ER and how often it's done. Attempt a nasotracheal intubation. You need, maybe it's not a very familiar territory for people to do. With the back valve mask device, we have already said that his beard is making it difficult for us to have a very nice seal to ventilate this gentleman properly, and probably the tongue has already fallen back in this individual. Ventilate the patient with a back valve mask device until his beard can be shaved for a better mask to fit. Of course, this answer sounds a bit fidgety, and so I think the most correct answer would be in the options given to reattempt the orotracheal intubation with assistance, if you have assistance, while keeping the spine aligned. I don't know if Mary has something.
No, I will say, because, this patient absolutely needs a definitive airway. The GCS is 6 and not breathing well, and so it's unfortunate that you wouldn't be able to, maybe to do some, pre-oxygenation with a bag valve mask while you're getting set up for the tube. But one thing I will say, particularly in a situation where a definitive airway is gonna be a while or whatever, what you can do with beards is if you have any kind of jelly stuff around, like KY jelly or ultrasound gel, anything like that, put a lot of the gel on the beard, and that will sometimes allow you to get a seal. But the problem is when you're pressing down, there's all that air between the bristles of the beard. If you just put a lot of jelly or ultrasound gel on the beard, you can sometimes get a good enough seal to ventilate. Just a little emergency measure if you're in a bind.
Thank you very much, the experts. The other potential question was the fourth, which was talking about a patient who arrives in the emergency department after being beaten on the head with a wooden club. He is comatose and has a palpable depressed skull fracture. His face is swollen and ecchymotic. He has gargling respirations and vomitus on his face and clothing. The most appropriate step after providing supplemental oxygen and elevating the jaw is, the two most common answers was A, which was request for a CT scan, and the other was B, which was suction, the oral pharynx. So we'll give you a chance to our experts again to comment on this.
So we have to go back to Dr. Mary's presentation on the priorities of care in the primary survey. That airway may be patent for now, but it's at risk of compromise. And the reason it's at risk of compromise is because of the patient is already demonstrating gargling respirations and vomitus. So as an adjunct to the airway in A, we need to quickly suction that airway before we proceed. This patient may get respiratory arrest while in the CT scan line, waiting for this CT scan. So once again, the ABCDE's priorities in management of this patient ensue. The adjunct suction is an adjunct to airway in A. So I think this is a patient who right now needs a suction as compared to a CT scan.
Again, until you fix A, you can't move on to B or C or D or anything, so.
Thank you very much. I will now request for all of us, please turn on your videos so we can take screenshots. Please turn on. Our next session is going to be next 2 weeks. We'll communicate. And for those who are in a part of React teams, watch out for us. We may be reaching you sooner than you think. So please turn on your videos.